Yun ang significance ng relations of the first part of the duodenum. Okay, guys? So, posteriorly, pwede mag-bleed ang gastroduodenal artery if mag-pull siya ng posteriorly. Second part is about 8 to 10 centimeters long. It descends along the right side of L1 to L3 vertebra. It's related anteriorly to the fundus of the gallbladder, posteriorly to the hilum of the right kidney. It's also medially to the head of the pancreas. No? Third part, 10 centimeters long. It crosses the L3 vertebra. It's near the root of the mesentery of the small intestines. It's posteriorly, it is related to the right ureter, the right psoas muscle, superiorly the head of the pancreas. Lastly, we have the fourth part of the duodenum, which is shorter, about 2.5 centimeters long, beginning at L3 superiorly and as far as the superior border of L2 and continues with the jejunum. So this is the last part, and this is the one that attaches to the duodenum actually. Now, let me mention this important muscle structure, or the ligament of Treitz. It's actually the structure that holds the duodenojejunal flexure. No, the connection between the duodenum and the jejunum is held in place by a ligament, or ligament of Treitz. This ligament, if you can see, this is a sagittal view. No, this image is a sagittal view. If you view it from the side, no. This is the ligament which actually connects this flexure, duodenojejunal flexure, to the diaphragm. So it holds it in place. No, so it arises from the right crus of the diaphragm, close to the esophagus, and passes downwards behind the pancreas, and is attached to the posterior surface of the duodenojejunal flexure, and the third and fourth parts of the duodenum. Now, clinical significance of this ligament, no, when you say upper GI or lower GI tract, this is the demarcation. No? When you say upper GI, all the structures that is proximal to it, no, the first part of the duodenum, the stomach, the esophagus, is upper GI. No? Sinabi upper GI bleed. Yan ang kanyang demarcation. From the esophagus, the stomach, down to this area. So anything distal to this is the lower GI tract. Okay? The ligament of Treitz ang marker mo for the upper or lower GI. That's the significance. Blood supply. Arterial supply comes from the superior pancreatico-duodenal artery and the inferior pancreatico-duodenal artery. Venous supply. The veins of the duodenum drain into the splenic, the superior mesenteric, and portal veins. Okay. Next is the jejunum. The jejunum is the midsection of the small intestine connecting the duodenum to the ilium. It is about 2.5 meters long, ganun kahaba, no? And contains the plicae circularis and the villi that increases its surface area. Products of digestion are also absorbed into the bloodstream here. So sugars, amino acids, fatty acids are absorbed in this area. Again, the suspensory muscle of the duodenum marks the division between the duodenum and the jejunum, in the ligament of Treitz. Next is the ilium, the final section of the small intestine. It's about 3 meters long, and it contains villi similar to that of the jejunum. No, it absorbs mainly vitamin B12 and bile acids, no, as well as some other remaining nutrients, but mainly vitamin B12 and bile acids. The ilium joins the cecum of the large intestine at the ileocecal junction. Now, in patients where the ileocecal junction or the ilium is removed, no, nagkakaroon sila ng problem with vitamin B12 deficiency. So, naging anemic. Some people have become anemic because of deficiency in vitamin B12. Okay. Blood supply. The ilium and jejunum are mainly supplied by the branches of the superior mesenteric artery. No? Intestinal branches arise from the left side of the artery and run in mesentery to reach the gut. They anastomose with one another to form a series of arcades. No? However, the lowest part of the ilium is supplied by the iliocolic artery. No? Venous drainage, which veins corresponding to the branches of the superior mesenteric artery, and they drain into the superior mesenteric vein. No? So these arteries, the arteries that supply the ilium and jejunum have their own corresponding veins of the same name. Nerve supply. For the duodenum, we have nerves derived from the sympathetic T6 and T9 and parasympathetic vagus nerve. from the celiac and superior mesenteric plexuses. And from the jejunum, we have nerves derived from the sympathetic and parasympathetic vagus nerves from the superior mesenteric plexuses. Okay. Now I mentioned about the I touched on the mesentery, no. This is the bronchine kanina, the one that I pointed out. This structure which holds the small intestines in place, no. It also holds many blood vessels. It's a broad fan-shaped fold of peritoneum that suspends the jejunum and ilium from the posterior abdominal wall. It also conveys the nutrition and innervation. Its free border separates to enclose in jejunum and ilium. So this is the important function of the mesentery, to hold the bowels in place and to convey blood vessels to it. No. Next, we go to another important feature of a small intestine are the lymphatic follicles. No. The mucous membrane of the small intestine contains two types of lymphatic follicles: the solitary lymphatic and the aggregated lymphatic, or the Peyer's patches. Now, it's actually the Peyer's patches that are involved when you have typhoid, no, typhoid fever. Now, when you see during colonoscopy, you will see that the Peyer's patches in the ilium are actually ulcerated, no. So that's involved during typhoid fever. Another important feature of the small intestine are the plicae circularis, or circular folds, or the valves of trickling, or valvulae conniventes. No? These are large valvular flaps projecting into the lumen of the small intestine. Actually, they begin in the second part of the duodenum. So this is a distinguishing feature of the small intestine, the plicae circularis. Now, the differences between the jejunum and the ilium. So grossly, the jejunum is deeper red, no, compared to that of the ilium, which is paler. Its walls are thicker and heavier compared to that of the light and thin ilium. It has greater vascularity in the jejunum compared to the ilium. The arcades that are seen in the mesentery are few, large loops, compared to the ilium with many short loops. No? The vasa recta are longer compared to that of the shorter vasa recta in the ilium. There is, however, lesser fat in the mesentery of the jejunum compared to that of the ilium. And the circular folds, or the plicae circularis, are closely packed in the jejunum compared to the ilium, mas konti. So if you see in an X-ray or in a grossly, if you see that the bowel has more circular folds or the plicae to it, it's actually the jejunum, no? However, babawi ang ilium with the number of the lymphoid patches or the Peyer's patches, so it's more abundant in the ilium. Okay, so again, grossly, here are the closer packed circular folds or the plicae circularis. And however, we also note the more abundant nodular structures in the ilium, which are the Peyer's patches. Lesser fat, the yellow thing is the fat in the jejunum compared to that of the ilium. Longer vasa recta, no, compared to the more complex vasa recta in the ilium. Okay, are we good so far?
Yes, pa.
Okay. Now, for the layers of the walls of the small intestine, actually, you discussed this. You might have discussed this in the histology. I'll just touch on it a little bit, no? You have the serosa, the muscular coat, the submucosa, and the mucosal coat. The serosa is actually made of peritoneum. The muscularis is made of smooth muscles arranged in outer longitudinal and inner circular layers, or OLIC, or O-L-I-C. Yun ang mnemonic nyo. You can use that, no? Outer longitudinal, inner circular layer, muscular layer. The submucosa contains the loose connective tissue and the large venous plexuses, containing the glands of the Brunner's. No? And the mucosa is composed of layers of epithelium, the lamina propria, and the muscularis mucosa. The plicae circularis and the Peyer's patches are actually contained in the mucosa layer of the lumen. Okay. Now we go to the large intestines. Okay. Now the colon is a distal part of the gastrointestinal tract. It extends from the cecum to the anal canal, no? Anatomically, the colon is divided into 4 parts: the ascending, the transverse, the descending, and the sigmoid colon. It averages 150 to 150 centimeters now. So this is your colon. This is how it is situated grossly, through the skin of the patient, Yung ganitong position niya. This is actual image, a representative image, not an actual image. We have your ilium, which connects to this part of the ascending colon. We have your first part, the cecum, the ascending, the colic flexure or the hepatic flexure, the transverse colon, the left colic flexure or the splenic flexure, the descending colon, the sigmoid colon, and finally the rectum. Okay, this is the anatomy of the large intestine. The large intestine can easily be distinguished from the small intestine by the taenia coli, which is a 3 thickened bands of longitudinal muscle. Also, we can see the circulations within the walls, known as the hostrations. We also see appendices epiploicae, which are our omental appendages, which are small pouches of omentum filled with fat, yellowish structures along the length of the colon. And the largest intestine, as the name implies, is larger in caliber compared to that small intestine. So yun ang distinguishing features. Now, we mentioned of the taenia coli, which are thickened bands of smooth muscle, representing most of the longitudinal coat. The taenia, this begins at the base of the appendix. Okay, from here, this is your appendix. It begins here at the base, as a thick longitudinal layer of the appendix, which leads to form 3 bands. So this is thick longitudinal muscle. It splits to form 3 bands along the length of this whole intestine, of the whole large intestine. The taenia runs the length of the large intestine, merging at the recto-sigmoid junction into a continuous longitudinal layer again around the rectum. Okay. Now, we also mentioned of hostrations. These are multiple pouches. Itong mga undulating or itong mga parang mga sac-like structures along the bowel length, along the large bowel. These are multiple pouches in the walls of the large intestine, where this is actually where the longitudinal muscle layers of the wall of the large intestine is actually deficient. So these are also known as saculations, hostrations or saculations. Again, also mentioned of the appendix epiploicae, or the omental appendages, which are fat-filled pockets of peritoneum projecting from the visceral peritoneum on the surface of the large intestine. So there are many appendix epiploicae on the large intestine, except the rectum. That is this one. These are the small outpouchings, yellowish fatty outpouchings along the length of the large intestine. Epiploic appendages. The first part of the large intestine is the cecum. Okay, it's actually a sac-like structure, which is continuous with the ascending colon. It's a broad, blind pouch and it's about 5 to 7 centimeters in length, located in the right lower quadrant, about 2.5 cm. So the ilium, the ilium is actually opens into its superior part. The ilium actually it connects with the cecum, not the ascending colon. It connects with the cecum in its superior part, and about 2.5 centimeters inferior to this, or below this insertion, is the vermiform appendix. Unlike the ascending colon, the cecum is intraperitoneal. Okay. Next is the vermiform appendix. It's a narrow, worm-shaped blind tube. In ultrasound, it actually describes this as a tubular peristaltic blind ending structure. That's how we describe it in ultrasound. It is variable in length, averaging 8 centimeters. It joins the cecum about 2.5 centimeters inferior to the ileocecal junction, as I mentioned earlier. It is relatively longer in infants and children than in adults. Now, the appendix has its own mesentery, called the mesoappendix. It suspends it from the mesentery of the terminal ilium. Now, the position of the body appendix is variable. It could be retrocecal at 65% of the time, or behind the cecum. It makes it hard for us to see it in ultrasound. It makes it hard for us to look for it because it's can you see me, guys, pala? Can you see me in the picture? Sorry.
Okay. Yes, Doc.
Dali, yan na pala nabasa message. I was, retrocolic, okay. Sorry, dali. So it makes it hard for us, lalo na tayo kami mga radiologists, when we are trying to look for it during, if we're trying to rule out appendicitis, no? When it's behind the cecum, the gaseous part of the cecum, excuse me. So it obscures the appendix most of the time. So it's pelvic in location 31% of the time and subcecal 2.3% of the time. But the base of the appendix is fairly constant, no? It usually lies deep at the junction of the lateral and middle 1/3 of the line, joining the ascis and the umbilicus. We will discuss this Magnonius point in the next slide, no? Now the three taenia coli of the cecum converge at its base and form a complete outer longitudinal coat for it. So this statement is actually important during surgeries, no? Because, okay, so this is your McBurney's point, no? Your McBurney's point is 2/3 of the way from the umbilicus. So you draw a line, you palpate, yung mga PT dyan, you can actually know where the ascis is, no? You palpate your ascis, no? And then you draw an imaginary line to the umbilicus. Now you divide it into three, no? Yung first division, which is 2/3 away from the umbilicus, is actually approximately the area of the base of the appendix. No? Sabi nga dun sa previous statement, the distal part may actually vary in location, but the base is fairly constant. No? Now this is important when you do an operation, because if you do a slit, no? If you do an incision in this area, mahirapan ka pang hanapin, no? If you don't know your landmarks, no? If you're McBurney's, mahirapan ka pang hanapin yung appendix. However, if you do a slit on this area, and then nakaagad, no? Again, the statement as I mentioned earlier about the taenia coli. Some surgeons kasi, when they fail to localize the appendix, they just look for the taenia of the colon, of the cecum, and then of the colon, and then trace it backwards, no, and trace it downwards until you reach the base of the appendix. Because nga, di ba, the taenia is at the beginning of the taenia is at the base of the appendix. Okay, so that's the importance of this point, the McBurney's point. Okay, are we clear with this area?
Yes, Doc.
All right, good. Okay, so this is just another image, no, showing the internal position of the appendix. This is your cecum. This is your entrance of the ilium. This is your opening for the appendix. The ilium is actually guided by an ileocecal valve, no, which is a flap of peritoneum. However, this valve does not function as a valve. Actually, it's the ileocecal sphincter, which is I mentioned earlier. It's located at the ilium side, which acts as the valve, not this ileocecal valve. Again, these are the different positions of your appendix, of the distal part of the appendix. It's behind the cecum 64% of the time, and pelvic 32% of the time. Okay, guys. Next is, okay, so let's discuss if the appendix is inflamed. So this is a fairly common phenomenon. No? I'm sure everyone has encountered this, no? When the appendix is inflamed or appendicitis. It is the acute inflammation of the appendix, most common cause for acute severe abdominal pain. The abdomen is most tender at the McBurney's point, okay, as I mentioned earlier. This corresponds to the location of the base of the appendix. Now, initially, the appendicitis causes a vague pain in the periumbilical area. No? Now, as the appendix swells, it actually irritates the parietal peritoneum and causes severe pain in the right lower quadrant. Okay, so it's actually the peritoneal irritation that causes the rebound tenderness. No, so when you palpate your right lower quadrant and there's pain, you will actually be sure. You can be sure that it's the parietal peritoneum is already inflamed. No, di ba? Mayroon tayong rebound tenderness. You will discuss this more in your second year or third year, I think. You have your rebound tenderness, your direct tenderness, di ba? So this happens when your parietal peritoneum becomes inflamed. If the appendix is not removed, it can become necrotic and actually rupture, resulting in peritonitis. And when this happens, the contents within the enlarged appendix actually is spilled out to the peritoneum. So instead of incision here in this area, a small incision in this area, pag nag-rupture na, nagiging malaki na. Dito na, mas malaking hiwa na sa gitna. Because you have to clean the area pa para malinis, no? Para to prevent sepsis, no? So that's the importance of actually diagnosing it before it ruptures. This is an ultrasound image of an appendicitis, no? This arises from this area of the cecum, okay? As you can actually see edema or fluid around the appendix, no? So this is your ultrasound image of the appendix. After the cecum, we go to the ascending colon, which is located in the right paracolic gutter and is covered by peritoneum on the front and the sides, which binds it to the posterior abdominal wall. Now, along its length, the posterior surface is located above the iliacus, the quadratus lumborum, and the transversus abdominis muscles. Now, during its course, it crosses three nerves: the cutaneous nerve of the thigh, ilioinguinal nerve, and iliopygastric nerve. Now, after the ascending colon, we now reach your right colic flexure, which is also known as the hepatic flexure, which lies anterior to the lower part of the right kidney and inferior to the right lobe of the liver. Now, after the hepatic flexure, we now go to the transverse colon, which is about 20 inches in length. It is the most mobile part of the large intestine. Now, it stretches between the colic flexures, no, from the right colic flexure to the left colic flexure. Well, strictly speaking, the transverse colon isn't actually completely transverse, no. There's a dependent loop in the middle part. Okay, this loop actually may reach up to the level of the umbilicus, so it's not actually transverse. It's a misnomer. It's actually more of U-shape, no, U-shape. Now, for the difference, the transverse colon has can be divided into the right 2/3 and the left 1/3, no. The right 2/3 is derived from the mid-gut during embryogenesis, no? And the left 1/3 is derived from the hindgut. The middle colic artery supplies the superior mesenteric artery, while the left colic artery supplies the left 1/3. Middle colic supplies the right 2/3. Left colic supplies the left 1/3. The middle colic comes from the SMA, left colic from the IMA. Nerve supply is also different. Vagus nerve for the right 2/3, pelvic splanchnic nerve for the left 1/3 of the transverse colon alone. Now we reach the left colic flexure, also known as splenic flexure. No, it lies anterior to the left kidney and inferior to the spleen. Now we go to the descending colon. This is actually longer than the ascending, no, 25 centimeters, but it's narrower and more deeply found, no, than the ascending colon. It spans the left colic flexure to the very front of the neck external iliac artery, no, and is continuous with the pelvic colon or the sigmoid colon, covered by peritoneum on its front, on its sides, and it's fixed to the left paracolic gutter and the iliac fossa. Now, the proximal part of the descending colon descends vertically downwards from the left, no. So on its course, again, it traverses the quadratus lumborum, transversus abdominis, and iliacus muscles, as well as the iliohypogastric, ilioinguinal, and cutaneous nerves of the thigh. The distal part turns medially from the neck iliac fossa to the very front of the internal and external iliac vessels. Okay, next is the sigmoid colon or the pelvic colon. The sigmoid colon is around 15 inches long and is attached to the descending colon it attaches the descending colon with the rectum. It is S-shaped, hence the name sigmoid, no? It goes from the lower end of the descending colon in the left pelvic inlet to the pelvic surface, where it becomes continuous with the rectum. So during its course, it creates a sinus loop which hangs free in the lesser pelvis. Now, in the pelvis, it's located in front of the bladder and the uterus below the loops of the ilium. Okay, the loops of the sigmoid colon contains three parts, no? The first part runs downward in contact with the left pelvic wall, no, as it arises from the descending colon to the left. The second part traverses the pelvic cavity, transverses the pelvic cavity between the bladder and the rectum in males, or the uterus and the rectum in females. And the third part runs backward to get to the midline in front of the third sacral vertebra. The rectum is about 5 inches long, which is the final part of the large intestine. It begins in front of the third sacral vertebra as a continuation of the sigmoid colon. It passes downward, following the curve of the sacrum and the coccyx. It ends roughly in front of the tip of the coccyx by piercing the pelvic diaphragm and becomes continuous with the anal canal. No? The lower part of the rectum is dilated to form the rectal ampulla, and the pubirectalis portion of the levator ani muscles forms a sling at the junction of the rectum with the anal canal. Peritoneum covers the anterior and lateral surface of the first upper third of the rectum, but only the anterior surface of the middle third. Now, the distal third of the rectum is devoid of peritoneum. Now, relations of the peritoneum. Posteriorly, the rectum is in contact with the sacrum of the coccyx, no, the sacral bones, so it's near the bones, no. It's also posteriorly related to the piriformis, the coccygeus, and the levator ani muscles, no, as well as the sacral nerve, sacral plexuses. Anteriorly, in males, the upper 2/3 of the rectum is related to the sigmoid colon and the course of the ilium, while the lower third is related to the bladder, termination of the vas deferens, and the seminal vesicles on each side. So this is anteriorly for males. In females, instead of the rectus vesical pouch, the upper 2/3 is related anteriorly to the recto-uterine pouch, or the pouch of Douglas, cul-de-sac of Douglas. No? The lower third of the rectum is related to the posterior surface of the vagina. Okay. Now, I mentioned of the paracolic gutters. The paracolic gutters are actually two spaces between the ascending and descending colon on each side, no? And the posterolateral abdominal wall. So these structures are clinically important as they allow infective material or fluid that has been released from the abdominal organs to accumulate it elsewhere in the abdomen. So it actually functions as a canal, no? So canal for fluid or infective debris, no, on each side, para hindi siya kumakalat. Okay, the paracolic gutters. Now, anatomic relations of each segment of the colon. The ascending colon anteriorly is actually related to the small intestine, the greater omentum, and the anterior abdominal wall. Posteriorly, the ascending colon is related to the iliacus, quadratus lumborum muscles, the right kidney, the ilioepigastric and ilioinguinal nerves. The transverse colon is related anteriorly to the greater omentum and anterior abdominal wall. Posterior to the transverse column, you will see the duodenum, the head of the pancreas, and the jejunum and the ilium. Now, for descending colon, anteriorly, you will see a few loops of small intestine, the greater omentum, and the anterior abdominal wall. Posterior to the descending colon, you will see the iliacus and the quadratus lumborum muscles, the left kidney, and some ilioepigastric and ilioinguinal nerves. And finally, for this colon, the sigmoid colon, anterior to the sigmoid colon, you will see the urinary bladder, the uterus, and the upper vagina in females. And posterior to the sigmoid colon, you will see the rectum and the sacral bone and the ilium, a part of the ilium. Now, arterial supply, as a general rule, no, those structures that are midgut derived are supplied by the SMA, or the superior mesenteric artery. And those that are hindgut derived are structures supplied by the inferior mesenteric artery, or the IMA. So the midgut derived structures are actually structures spanning the lower part of the esophagus to the stomach, to the duodenum, to the small intestine, down to the ascending colon, down to the right 2/3 of the transverse colon. Diba I mentioned earlier the right 2/3 and the left 1/3. That's the junction. So from the stomach down to the right 2/3 of the transverse colon, superior mesenteric. Now from the left 1/3, the left 1/3 of the left 1/3 of the transverse colon down to the descending colon, the rectum, the sigmoid, IMA na siya. Okay? That's the demarcation line, the transverse colon. The colon is supplied by the following arteries, no? Iliocolic, right colic, middle colic, left colic, sigmoidal, and superior rectal arteries, which are branches of the corresponding arteries, superior and inferior mesenteric arteries. Okay? Now, the supplies of the distinct parts or specific parts of the colon, the ascending colon, the lower smaller part is supplied by the iliocolic artery, its bigger upper part by the right colic artery. Again, transverse colon, as I mentioned earlier, right 2/3, middle colic, which is a branch of the SMA, left 1/3, left colic, which is a branch of the IMA. Okay, so descending colon, left colic artery, again a branch of the IMA. While for the sigmoid colon, we have the sigmoidal branches of the inferior mesenteric artery and the superior rectal artery. Okay, these are the specific branches for the specific areas of the colon. Venous drainage, no? The veins emptying the colon follow the arteries. So from right colic artery, we have right colic vein, no? The veins accompanying the iliocolic, the right colic, and the middle colic arteries actually join the superior mesenteric vein, while the veins accompanying the branches of the inferior mesenteric artery join the inferior mesenteric vein. Ultimately, these two veins drain into the portal venous flow. Okay? Lymphatic drainage. Lymphatic drainage of the colon is medically very essential, no? Because during when you have colon cancer, the colon propagates the cancer cells propagate via the lymphatic route. There are numerous colic lymph nodes. Okay, we have epiploic nodes located on the walls of the colon. We have paracolic nodes along the medial edges of the ascending and descending colons. And we have intermediate colic nodes located along the iliocolic, right colic, and middle colic arteries. Now we have grossly, it's in your book also, the difference between the small and the large intestine. This externally, you see that the small intestine, with the exception of the duodenum, is mobile, no? Whereas only the ascending and descending parts of the colon are fixed, no? Well, the transverse is mobile. Transverse colon is mobile. The caliber for the small intestine is smaller, well, as the name implies, compared to that of the large intestine. The small intestine, again, with the exception of the duodenum, has a mesentery that passes downward across the midline. The longitudinal muscles of the small intestine forms a continuous layer around the gut, around the gut, with the exception of appendix, of course. While for the large colon, the longitudinal muscles are confined into three bands known as the taenia coli, only on one side. The small intestine has no fatty tags or the omental appendages, no? The large intestine has fatty tags, yellowish structures along the length of the large intestine. The walls of the large intestine is smooth, no? Compared to the sacculated walls of the large intestine. Okay. Internally, the mucous membranes of the small intestine has a permanent folds known as the plicae circularis, which are absent in the large intestine. The mucous membrane of the small intestine has villi, which are again absent in the large intestine. As well, we also have the lymphoid tissues, also as I mentioned earlier, or the Pierce patches, abundantly found in the ilium, which is also absent in the large intestine. Okay, so we're now in the last few slides. We will now discuss common pathologies of the small and large intestine. So we still have 30 minutes now before your next lecture. Okay, first part. This is the most common congenital abnormality of the digestive tract of the small intestine. This is the Meckel's diverticulum. It is a congenital diverticulum or outpouching which arises from the anti-mesenteric border of the terminal ilium. So during the 8th week of gestation, the omphallomesenteric or the vitelline duct, vitelline duct normally undergoes obliteration. The vitelline duct during the early parts of your fetal part of your development is the one that connects the developing embryologic gut to the yolk sac. It's the vitelline duct that connects it for nourishment. So as the fetus grows older and the gut actually develops, it should undergo obliteration during the 8th week or the second month of your fetal life. However, if you fail to, or if there's failure or incomplete obliteration of the vitelline duct, some congenital abnormalities occur. The most common of which is the Meckel's diverticulum. Okay. The Meckel's diverticulum actually contains heterotopic tissue, most commonly gastric tissue. So it is a structure within the small intestine, within the ilium, but its lining is composed of gastric lining. So that's very peculiar for this structure. So gastric lining, pero small intestine structure. Kaiba. Again, we familiarize yourself with the rule of twos. So Meckel's diverticulum occurs in just 2% of the population. It is usually found 2 feet proximal to the ileocecal valve. So in the ilium, about 2 feet away from the ileocecal valve. It is approximately 2 inches long. It is 2 times more common in males than females. It becomes symptomatic only after 2 years of age. Sorry. It becomes symptomatic only before 2 years of age, mostly before 2 years of age. And in adult patients, it is symptomatic in only about 2% of the time. So that's your rule of twos, for the Meckel's diverticulum. So this is an example, crossly, surgically. We have this pouch here and the ilium. This is a pediatric patient. Maliit pa yung mga bawat, So this is actually mostly seen in the ilium, this small pouching. Now, what are the possible clinical manifestations when the Meckel's diverticulum becomes symptomatic? As I said, majority, so 98% are asymptomatic. Only becomes asymptomatic 2% of the time, particularly in adults. It may bleed. Severe hemorrhage. Diba, I mentioned that although it's a small intestinal structure, it actually has a gastric lining. So when you are stressed, the gastric lining actually produces HCl, so gastric acid. So it becomes a problem because the lining of the mucus is thinner compared to that of the stomach. So it's not able to hold that amount of acid. So when that happens, it becomes ulcerated. Ulcerated, eventually it bleeds. Nagiging ulcer siya. Next, it also becomes a lead point for indusception. Through this area, the bowel, I will discuss earlier in the next following slides, indusception. It can become inflamed, Meckel's diverticulitis, or sometimes it can cause obstruction. Next abnormality is intestinal malrotation. So during normal abdominal development in the fetal life, the 3 divisions of the GI tract, namely the foregut, the midgut, and the hindgut, actually herniates out from the abdominal cavity. It goes out, where then they undergo a 270-degree counterclockwise rotation around the superior mesenteric vessels. Now, following this rotation, the bowels return to the abdominal cavity, wherein the duodenojejunal loops are fixated at the left side of the midline, and the cecum is fixated at the right lower quadrant. Now, intestinal malrotation or intestinal non-rotation or incomplete rotation refers to any variations in this rotation and fixation in the GI tract during development. The most common type in pediatrics is incomplete rotation, predisposing to midgut volvulus. This actually requires emergent operative intervention. Midgut volvulus. Okay, these are some images of the different variations of malrotation. We have non-rotation, wherein the jejunum is seen on this side. No? We have mixed rotation with volvulus. We have mid-gut volvulus. You can see that the small intestine actually is looped around the large intestine. We have reverse rotation, and we have hernia or subhepatic or cecum and appendix. We study these images na lang. Okay. We also mentioned of the volvulus, which actually refers to a twisting of a loop of intestine around its mesenteric attachment. This may occur in various sites of the GI tract, no? But most commonly it occurs in the sigmoid and the cecum. Rarely does it happen in the stomach, the small intestine, or the transverse colon. It can result in partial or complete obstruction, or it may lead to ischemia. May also compromise bowel circulation when it twists around its axis. No? So, as I mentioned, the more common ones are the sigmoid volvulus and the cecal volvulus. The sigmoid volvulus accounts for 8% of all intestinal obstructions. No? Most common in elderly patients, especially those who are neurologically impaired. This is because it actually occurs in patients who have a history of chronic constipation. The cecal volvulus accounts for 11% of intestinal volvulus. Sigmoid is 8% of intestinal obstructions. No? Cecal is 11% of intestinal volvulus. It can result in bowel perforation and fecal peritonitis. Next is indusception, which I mentioned earlier. It is a clinical condition where a proximal section of the bowel actually invaginates into the lumen of the adjoining distal section. No? So it actually telescopes inside. No? So, this actually might cut off the blood supply to the bowel and cause gangrene. No? We have 3 different types. We have the ilioileal, wherein a proximal ilium invaginates into the distal ilium. We have iliocecal, ilium invaginates into the cecum. And we can also have colic, wherein the proximal colon invaginates inside another distal colon. No? However, iliocecal indusception is the most typical form. No? I mentioned earlier, the Megas diverticulum actually could lead, becomes the lead point, no, to cause the proximal bowel to invaginate inside the larger distal bowel. Okay, are we clear with indusception, guys?
Yes, po.
Okay, so last few slides lang to. Next, we have diverticulosis. This is primarily a large bowel abnormality. No, it is due to herniation of the lining mucosa by the circular muscles between the taenia coli. You can see the small outpouching. It can be singular, it could be numerous. No, yung mga small outpouchings na yan. Okay, the herniation takes place where the circular muscle coat is at its weakest or feeblest. No. When this diverticulum becomes inflamed, it is known as diverticulitis. No, a problem occurs when this diverticulitis actually ruptures, no, expelling out intestinal contents. So magkakaroon ka ng abscess formation in that area. Okay. Diverticulitis, diverticulosis. Next, we have the congenital megacolon or the Hirschsprung disease, which is a abnormality of the large distal colon of the newborn. No. It happens when the neural crests don't migrate and create the mesenteric plexuses in the distal, usually in the rectosigmoid junction. No? So when the area becomes aganglionic, it fails to relax. It is maintained in its contracted state. No, so this state ends in the absence of peristalsis. No, so wala siyang contraction, walang peristalsis. So consequently, the normal proximal colon becomes dilated because the feces fails to pass through the aperistaltic area. So they accumulate gas, fluid, intestinal contents accumulate in the distal colon, causing bowel obstruction or bowel distension. No? So that's the Hirschsprung abnormality. Finally, we have our last slide, which is cancer of the colon. No, this is a cause of death, which is top cause of death in the Western world, cancer of the colon. Most common in people who are 50 years old and above. That's why the surgeons advocate that when you reach 50 years old, you should have at least a regular colonoscopy. No, it's also common in people, patients who are non-vegetarian. This is actually a slow-growing tumor, no, causing constriction of the colon. It's slow-growing. That's why it sometimes it has already spread to different parts, no, to the regional lymph nodes, as I mentioned earlier, no, as well as the distal parts such as the liver, no. In advanced cases, it spreads to the liver via the portal venous circulation coming from the inferior and superior mesenteric veins, diba, I mentioned earlier. However, if it's diagnosed early, no, you can actually do hemicolectomy, and we can including dissection of the regional lymph nodes that are involved. This is actually very much curative, no. So this is an example of a polyp or a mass that is seen within the lumen. That causes partial obstruction, actually. No? You know, the luminal area, the affected part of the lumen is actually very narrow na. Okay? Colon cancer, sometimes its manifestations are constipation. No? Especially in these types of cancer. In the second image, this is a barium study pala. Okay? When sometimes the cancer is eccentric, no, or infiltrative, or it actually involves just the wall. Wala sa mass, it involves the whole wall of the colon. So when you do barium study, it actually looks like this. This is your apple core deformity, no. If you can see, it looks like an apple that's been eaten already. No? You just leave the core, the apple core deformity in colon cancer. Okay, guys, this is my last slide. Thank you very much for listening. Do you have questions?
None so far, Doc.
So far, so near, wala. Attendance ngayon, may nakita attendance? No attendance? We have attendance?
Yes, Doc. Miss Ansing ko took down the notes of those who attended the class.
Okay. How can I go to large screen view so that I can see? Paano ba to?
Exit.
Exit. Tapos paano ako mag large screen? How do I stop share? Yan.